Hello, everyone. I'm Leah Binder. I am President and CEO of the Leapfrog Group, and I welcome you to today's webinar when we are going to discuss an extremely exciting new program called Recognized Leader in Caring for People with Diabetes, a joint initiative of the American Diabetes Association and the Leapfrog Group. So here's a few housekeeping details before we get started. Accessing the audio. If you're using computer audio, select the option in the audio options that pop up. If you're joining by phone, please dial in using the toll-free 800 number provided, and you can see the further instructions on the screen. If you have a question or a comment, please feel free to enter that. We are not certain we'll get to all the questions today, but we welcome your comments and questions, and that will be very helpful to all of us. So please use for that the Q&A button that's on the bottom of your screen. So the chat function that so many of us are used to on Zoom is not for this meeting. Use Q&A. If you use chat, we might still pay attention to you, so don't worry, but better that you use the Q&A function. And then finally, we will be recording today's session, and the recording will be available on the website that's listed on your screen through the leapfroggroup.org. And next slide. Again, there's that Q&A. Q&A, that's how you enter your question or your comment. And then you can also raise your hand if there's time. We will be able to call on people directly, but we'll see if there's time. Next. All right, so these are the participants in today's webinar. In addition to myself is Robert Gabbay. He is the Chief Scientific and Medical Officer at the American Diabetes Association, the partner on this project. We also have Tara Rose Murphy. She served on our expert panel for this project, is herself living with diabetes, and she'll talk a little bit more about that, but also is an expert on healthcare measurement. So was an incredible resource to our expert panel. Guillermo Umpierrez from Emory University School of Medicine also served on our expert panel, and as did Andrew Paul Demidowich, who was from the Johns Hopkins University School of Medicine and handled much of the science behind the development of our questionnaire. So let's get started. So the first question we, of course, want to ask is why are we addressing diabetes? A lot of people think, well, why? Leapfrog's known for its work for inpatient care, for hospital inpatient care. We also do actually have ratings for outpatient surgery and ambulatory surgery centers now, but that's relatively new for Leapfrog. Our tradition has been inpatient care. And a lot of people say, well, why are you looking at diabetes for inpatient care? They think, a lot of people just sort of assume that's completely an outpatient issue or a physician practice issue, which it certainly is. But what we discovered and learned at Leapfrog from Dr. Gabbay and others at ADA is it is very much a critical issue for inpatient care, critical issue to patients. So before I get started on talking about the particular program and the issue that we're doing, let me talk a little bit about Leapfrog for those of you who might not be familiar. So Leapfrog was founded in the year 2000 by employers and other purchasers of health benefits. Some of the logos are below. We now have thousands of employers involved with Leapfrog. Our mission is giant leaps for patient safety. The original founders of Leapfrog, or these companies, felt strongly that they wanted to see major improvement in patient safety. So the problems in hospitals that we know happen a lot, which are like medical errors, infections, just mistakes, problems, things like that, that sometimes harm patients and even kill some patients. This is a problem that is far too common, is still today. And these executives really wanted Leapfrog to publicly report how hospitals were doing to address patient safety, to improve the safety of their patients, and then publicly report by hospital. And we started out by asking hospitals, on behalf of these purchasers, these that you see here and many others, could you please give us the data on how you're doing? And then over time, show us how you're improving. And that's exactly what we have done for 23 years since the founding. We've gotten a little better at it. We're a little bit more lot more sophisticated thanks to developments in measurement science. But fundamentally, our principle is an open and transparent market for healthcare to drive improvements in healthcare for all Americans. Next slide. So there's a number of reasons why hospitals and, as I mentioned, ambulatory surgery centers as well, give data to Leapfrog in our annual surveys. Part of it is they are also committed to transparency. We've seen an enormous renaissance in the hospital community and in ASCs in this approach to transparency, where I think in the old days, like when my grandmother was using hospitals, they thought that's not something you need to know about. But now I think hospitals themselves recognize the value of transparency, and they are very much on board with that. They also want to benchmark their performance. It's important to know, how am I doing? Maybe I think I'm doing great, but it turns out maybe I'm not doing as well as other hospitals that are similar to mine or other ASCs like that. So it helps to benchmark to see where you compare. A lot submit, and Leapfrog, because we're transparent, you can see immediately how you compare. We like to galvanize improvement, and hospitals and ASCs use Leapfrog to galvanize their own communities, whether it's those who use their hospitals or those internal to their hospitals, their clinicians and their staff, to show them here's where we are and here's where we want to be. There's nothing like Leapfrog to help them really move that dial. They use it to predict their status in value-based purchasing programs. Leapfrog is very much a proponent of value-based purchasing, and it is also gives hospitals lots of insights into where they are. And finally, I think importantly, hospitals and ASCs want to respond to the requests of purchasers, employers, and other purchasers who are interested in how they're doing. I think that's also a very important point, because traditionally, again, when my grandmother was using hospitals, maybe in those days, we basically, employers didn't talk to hospitals, even though they were paying for the care of their employees at hospitals. They didn't talk to them, because everything was sort of negotiated through usually a health plan or maybe Medicare, some kind of a third party. And that still happens, but it's very important to actually have a relationship with the hospitals in your community. And it's important for those hospitals to have a relationship with the business community that has so much invested in their success. And that's a fundamental principle of Leapfrog, a direct connection and really collaboration, strong working relationship between the business community and purchasers, as well as the advocates for patients and families. Next. So, as I said earlier, we discovered by learning from our colleagues at the American Diabetes Association just how important diabetes is in our realm of inpatient care. And I'm going to turn it to Robert Gabbay to let us know, why did you get involved in this, and why should diabetes really be a critical concern at the inpatient level?
Yeah, thank you for that. And this has really been a wonderful partnership, and I appreciate everyone that's listening into this, because this is really important. So you might say, why diabetes? Well, 37 million people living with diabetes, but most importantly for this audience, those individuals are 8 million individuals with diabetes are admitted to hospitals each year, and that represents 22% of all hospital admission days. That is a very significant. So it's hard to be doing good care for people in the hospital without paying attention to diabetes. We know that better management of individuals with diabetes can reduce their complication rate in the hospital. And in fact, you'll see data, you'll hear data in a moment that shows that in general, people with diabetes do a lot worse in the hospital. The good news is that there are things that can be done to address that. There are also a huge health equity issue here as well. So we know that people from various minority groups and underserved populations often do so much worse. And one staggering statistic relates to amputations. So Black and Indigenous Americans are 2 times more likely to lose a limb when they're admitted to the hospital. So amputation rates are significantly higher. So we want to do something about this, and so the first step really comes from looking at the evidence. So what do we know works? And every year the American Diabetes Association publishes something called the Standards of Care, which are the globally recognized guidelines for diabetes care. And in that, there's a section around inpatient care, and this process involves a group of interprofessional experts looking at all of the research, and really from that saying, here's where the evidence exists. And so we know for some time now, actually, how we can improve the outcomes of people with diabetes. We know if we can achieve certain goals, people will do better. And really the effort here is, how do we go from that knowledge to action? This is not something that is only on our collective radars, but CMS has been thinking about this a great deal. There are a number of CQM measures, including one looking at hypoglycemia, low blood glucose, that are in the works, although not publicly sort of spread at this point. So we wanted to do something and not wait, because as you'll see the statistics in a moment, people are suffering. They're having worse outcomes, and at the same time, we know we could do better. So on the next slide, really the idea behind this program was really, how can we elevate the quality of care for people living with diabetes when they are in hospitals, and recognize hospitals that are really leaders in this area. And it was quite obvious to us that the group we needed to work with is the Leapfrog Group, and we're so happy to have this partnership with them. And so with that, I think I'm going to turn it back to you, Leah.
Great. Well, it has been a really remarkable partnership, just an amazing partnership. So I really am grateful to be able to work with you, and your entire team have been extraordinary. And I think this is going to make a big difference. And so more than anything else, that's what matters to us. And so to your point, this is about action and really seeing the change. And I think I know that hospitals want to see that change as well. And so now is an opportunity for us to bring them in and recognize them for their efforts. So in order to participate so there will be let me start with this. There will be an application which will be released on November 8th. We now have the date, November 8th. And hospitals that have submitted the 2023 Leapfrog Hospital Survey may participate and may complete the application. We do need your survey data, because that is part of the criteria for this. But also the survey may be submitted by, the deadline for that is November 30th. That's the final deadline for the survey. So November 8th, you can complete that. Now, the badge will be given. So if you are selected as a leader, then you're only the top performers, those that achieve the badge, will be displayed on Leapfrog's website, and will be announced in press releases and announced in our joint efforts at promotion of this through ADA and Leapfrog. But the hospitals that don't get the recognition won't be reported. So this is a little different for those hospitals that are familiar with working with Leapfrog. When hospitals complete the Leapfrog survey, we report all levels of performance on each of the measures. That's not what we're going to do with this. This is really a separate program for those that wish to do it. We hope that every hospital will want to do it, but it's for those that wish to, and we will recognize those top performers. Next. So now I'm going to turn to one of the members of our expert panel who's been just a fantastic team member on this project and really given us incredible insight. Tara Murphy. Tara, let's start with your telling us about your own experience. You have some experience with being in a hospital, and also as a person living with type 1 diabetes, correct?
That's right. Yeah. Thank you, Leah. Thanks for having me here to speak with everyone today. I was diagnosed with type 1 diabetes, actually only in August 2020. I was in the height of the COVID pandemic and later in life than usual. A fun surprise for sure. I was having vague but severe symptoms that progressively got worse and led to the old classics of, severe weight loss, extreme thirst, and all of the good ones that everyone is familiar with. I found out I was diabetic via an email from my primary care provider. One Friday morning. I was told, you have an elevated D-dimer. You might have a pulmonary embolism. Please go to the emergency room. P.S. You're diabetic too. So I went to the emergency room, quickly found out I did not have a pulmonary embolism, and was told I could go home. I would need to follow up on that diabetes thing, outpatient. A couple hours later, wondering where my paperwork was, someone came in and said, "Oh, no, you're in full-blown diabetic ketoacidosis. We're getting you an ICU bed." So because I was what you all called walkie-talkie, a very cute name. I like that. I was able to avoid the ICU. It was the height of COVID, and being able to stay out of the ICU was wonderful. So I was admitted just to the general floor, and I was in the hospital, treated for my diabetic ketoacidosis for, I believe it was about 6 days. When I was in the hospital, I learned sort of the basics of diabetes, what it was. I will say one of the funnier pieces of the story was that I had a hunch in the days leading up to my diagnosis that something was afoot, that maybe it had been diabetes. And all I knew about diabetics was that sometimes they need to drink sugar. So I was guzzling juice, thinking that certainly would help. It obviously did not, and certainly exacerbated the issue. So yes, I was hospitalized at that point for, that was when I found out, that's when I was diagnosed. Subsequent blood test confirmed it was type 1. And that was where I received my first introduction to diabetes management.
And so what did you, what did I learn? What did you learn about, or perhaps what would you advise the hospital that you were at, based on your experience?
So, I mean, there was a whole, I was a complete blank slate when I started in the hospital. I learned so much from the wonderful doctors and nurses who taught me everything from how to inject insulin to, what blood glucose even is. And so there was just a massive knowledge dump over the course of those few days. So it was definitely, I'd say a crash course that did set me up for the first couple of months for sure, until I really started to get into the nuances of managing this disease that I do think takes it takes getting into the weeds to really understand the complexities of it. I don't think there is a scenario in which I would fully have understood all that goes into managing this disease in those first few days. Some things that resonate in hindsight that at the time I don't think necessarily put me on the right path. I was desperate to go home and needed to get my blood sugar down, and yet was constantly offered graham crackers and apple juice with no insulin to accompany it. I not fully understanding the disease, I assumed there was something magical about graham crackers and apple juice that meant I could, ingest without any real worry, or that there was no reason. And then lo and behold, next blood work would come back, next blood tests would come back, and my blood sugar was still high, and I was in the hospital for another day. That was something that, as I left, I reflected on and sort of noticed it does seem as though there are differences in the way that patients think about their diabetes and the way that hospitals think about managing blood sugars sometimes. That is just a very tough gap to bridge. It's not an easy one to fix. Since I was diagnosed, I've been in the hospital 2 more times, once during my pregnancy and then once for the birth of my son. And I had similar experiences both times, which is, I think, the perspective that I think I bring to the table, which becomes obvious sort of within a few minutes of talking to me about this, is that patients are the best experts most of the time when given the appropriate information and properly educated. We know our management better than anybody. When we are properly educated on the trade-offs of our choices, when we're properly educated on how our bodies work, we are the ones who are sort of most vested in the good outcomes that we are all looking for. It is the patients who I think putting patients in the center of the decision-making process is going to get everybody what they want. So that is what I learned through my 3 hospital stays as a diabetic, is that I think if, with the support of the hospital staff, letting me be in the driver's seat is, I think, gonna get everybody what they're after.
I think that's very wise advice. But also, I think one of the perspectives that you brought, in addition to your own experience, which is extraordinary, is your background from National Quality Forum, from AARP's Public Policy Institute. Can you talk a little bit about what your reflection was on how we measure this in some kind of systematic way so that we can properly identify the hospitals that are leaders?
Yeah, that's a great question, and certainly a big one. It's actually sort of funny because working in quality measurement and even in my day job, not as a professional diabetic, I'm a researcher, and I do love some good, clean, categorical and numeric data. I know we would all love to live and die by that, and certainly it will get us very, very far. But as a patient, all I want to do is sort of like grab people by the collar and say, it depends. There's nuance, there's context. And frankly, I feel like, well, it depends could be the tagline for diabetes management. So I think, when it comes to the quality measures that will move us forward, I like a lot of the structural measures that Leapfrog is proposing in this set of measures that are around policies that allow hospitals to take into account the nuance of managing this disease. For example, the measure around self-management, it does lend that sort of flexibility, along with, coupled with the basic safety measures around hypoglycemic protocol. It does give sort of that, it allows for the nuance that I think is required in each of these situations. So yeah, I unfortunately can't crack the code on exactly how to measure these extremely complex processes and constructs in medicine. But I do think, the more that we allow for the patient voice to be centered, the more we will, the better off we'll, I guess the better we can measure that, the further we'll go.
Yeah, and that's the intention of this program.
Absolutely.
All right. Well, thank you for your hard work on this project and brought a great deal of fresh insight and important insight into where we went in terms of structuring this new program. So I'm going to turn it now to Guillermo Umpierrez from Emory University, who was the chair of our expert panel, an expert on diabetes, and take us through some of the issues around the diabetes epidemic in the U.S.
Thank you, Leah, and thank you so much, all of you, for joining us today. I'm an endocrinologist and diabetologist for the last 35 years that have been involved in diabetes care and conducted research in the hospital for the last 2 or 3 decades. And our group has put together a lot of new information on how we should manage patients with diabetes. But Bob Gabbay already showed some of this data. To the left of this slide is the epidemic of diabetes where we are. And to the right is that we know that patients with diabetes, both type 1 and type 2, are admitted 2 or 3 times more likely than a patient without diabetes. And the CDC reported 2 years ago or 3 years ago that there were 8.25 million discharged with diabetes. And the numbers will continue to rise. That's right. And I hope that very soon we have new data. And I would not be surprised that it's much more than 8.25 million hospital discharges with the diagnosis of diabetes. And whoops, next, please. And we also mentioned, Bob already mentioned, the importance of why we care about diabetes and why we need protocol, why we need guidance to improve diabetes care. These slides represent data on 3,200 non-cardiac surgery patients who were admitted to Emory University. These were general surgeries. And you see in the yellow are patients with diabetes and red patients without diabetes. And I'm showing here is that those with diabetes have an increased risk of complications. They get more pneumonia, more wound infections, sepsis, urinary tract infections, acute myocardial infarction, and acute kidney injury. And to the left is mortality. Those patients with diabetes should be very carefully followed and treated to prevent these complications. Next. But it's not just diabetes. To the left is what I already showed you. This is hospital death, reoperation, and composite in patients with diabetes. In the red, those with glucose greater than 180, and to the left, and in yellow, those patients with less than 180. I want you to focus your attention to those to the right side of these slides. And these are patients with no previous history of diabetes admitted to the hospital for whatever reason. And those with hyperglycemia or a glucose greater than 180 have more death, the need for reoperations, and significant rate of infections. And if you look at those slides in the right and compare to the left, those patients with what we call stress hyperglycemia have significant more complications. These data clearly indicate that hyperglycemia is important in both people with and without diabetes and should be treated. Next slide. And these are the current recommendations. Next slide, please. And what you have, click again, Jinko. And what we have here is in the top panels, what is the non-ICU, the general surgery, general medicine patients. And these are the current recommendations of the American Diabetes Association to keep the blood glucose between 100 to 180 milligrams. And there is not much difference. You target 100 to 140, 140 to 180. So this is important. We should avoid hypoglycemia and hyperglycemia because both the two extremes of glucose concentrations are associated with poor outcome. In the bottom is ICU with the new data now that become available from the American Association now feel very comfortable in saying the blood glucose for both non-ICU, ICU patients should be very similar. The Society of Critical Care also is recommended a blood glucose less than 200 for most people in the ICU. Next. So it is important to manage diabetes, but to do so, first we need to have guidelines about how to screen, when to screen with hemoglobin A1C or glucose levels. It is so important to differentiate those with newly diagnosed with previously diagnosed because we know that those patients who come with poorly controlled diabetes with high hemoglobin A1C do worse than those who have lower hemoglobin A1C. Second, management. Avoid hypos and hyperglycemia, as we mentioned before. The two extremes are associated with poor outcome. Third, assess patient education needs. As Tara already mentioned, it's so important to educate our patients. Unfortunately, diabetes education is provided to less than 10 to 15% of patients in this country when they're in the hospital by diabetes educators. Most of them receive just little education from nursing staff. So we really need to improve our patient education to improve diabetes care, both in the hospital and after the patient go home. And fourth, ensure appropriate diabetes management upon discharge. When you go home, doctors send you home the day after surgery or 2 days after surgery. As soon as you can walk, you hit the door. So how we're going to improve and link this, make the recommendation for the inpatient physician to go to communicate to the outpatient doctor. and how we should manage patients. Should everybody be on insulin? What kind of insulin? How aggressive we should be? So we need to have appropriate guidelines for all patients, all doctors and professionals who are involved in diabetes care. Next. So the American Diabetes Association and the Standards of Medical Care in Diabetes this year will quote, high quality hospital care for diabetes requires standards of care delivery, which are best implemented using a structure, order set, and quality assurance for process of improvement. So there is no question that we need guidelines. My hospital needs guidelines. My university needs guidelines. All of you need guidelines. And this is why I'm so proud. I'm so grateful with the American Diabetes Association and Leapfrog for allowing me to be part of this program. Back to you, Leah.
Well, with the the percentages that Dr. Gabbay gave us earlier, about 22% of beds with people with diabetes, and that's not counting, I don't think that's counting hyperglycemia. That is, those are extraordinary numbers. Every hospital needs to be worried about this. Also, I think your data is really interesting to me too, because it's suggesting that there are many advantages beyond simply the most important advantage, which is treating your patients with the best possible care. But in addition, you can prevent some of the issues that I think hospitals are generally worried about, such as readmissions or mortality, or some of the data you showed, I think, was very compelling about the ability to manage those outcomes.
Yeah, and listening to Tara that presented with diabetic ketoacidosis, for example, the American Diabetes Association just updated the guidelines for how to manage hyperglycemic crisis. If you have one episode of diabetic ketoacidosis, what we call DKA, mortality is 1%. But if you have 2 or 3, mortality is 3-fold. If you have more than 5, mortality increased by 5-fold. So education, and provide the guidelines for professionals in the hospital, how to manage this patient, how to prevent readmission is quite important. And there's no question that high and low blood glucose are associated with poor outcome. So we need guidance on how you manage patients. As the hospital have structured protocols. Countries with no protocols or hospital with no protocols to treat hyperglycemia in the hospital, they do worse. So I think that it's very clear to me that this program, I hope that it goes forward, and doctors and hospital administrators approve to work with us, because together we can make a tremendous difference in the management of patients, both in the hospital and when they go home.
There's a lot of lives at stake. I mean, based on your numbers, those are extraordinary numbers. So it's ever more exciting to be able to do this and to encourage hospitals to take a look at this at least. All right, so let's turn now to Andrew Demidowicz, who is going to tell us about what is in the application. What standards are we going to hold hospitals to in order to achieve this designation as a leader? So welcome.
Thank you, Leah. Appreciate it. First, actually, I want to start out by thanking our esteemed expert panel for their hard work and input on this project. We had multidisciplinary representation, including Jennifer Clements, our pharmacist, and CDCES, Chris Emory, who represented nursing, as well as, again, being a clinical certified diabetes expert in education. And then we had Dr. Kingsley, who is an intensive care expert, Dr. Neville, who is our expert regarding vascular diseases. Of course, we had wonderful endocrinology representation with Dr. Gian Chandani, Dr. Kwartkowski, Dr. Rubin, as well as Dr. Umpierrez. And lastly, and most importantly, that we had really tremendous input from patients themselves who have lived through hospitalizations with diabetes. We've already heard from Tara Murphy, as well as we also had Mr. Thornton, who was also on the panel. And truly, before going to the next slide, diabetes is so complex and multifaceted. There's really a large number of potential measures that could have been included in this recognition program. And the expert panel had much discussion and deep thought over a series of meetings to identify which measures were really the most meaningful and discerning without making the application overwhelming. As Dr. Gabbay mentioned, the panel leaned strongly on the ADA Standards of Medical Care Guidelines to help define the specific benchmarks for excellence in inpatient diabetes care. But also, as Tara mentioned, we really strongly relied on direct patient experiences and insights to determine what quality measures might be most important. Next slide, please. So without further ado, to give you an idea of what the actual measures are, we can see we had some structural measures. So specifically structures to support patient-centered care, diabetes self-management. So does the hospital have structures in place that facilitate self-management using insulin pumps and continuous glucose monitors? Patient-reported concerns. So does the hospital provide multiple reporting channels for patients to communicate concerns and implement a process to ensure that those concerns are addressed? Activation of rapid response teams. Does the hospital empower patients and their families to activate a rapid response team who can conduct an evaluation for an escalation of care? You can see a theme here that we really want to empower our patients and families. Also, does the hospital have a hypoglycemia protocol? Do they follow a specified hypoglycemia protocol to allow rapid treatment in emergency situations? And data collection on amputations. Does the hospital collect data on amputations or amputation rates? And really more importantly, do they participate in large national registries that would include data on amputations and allow them to then pursue quality improvement projects to improve their practices based on this data? Next slide. Additionally, we have key indicators with care processes. So for all patients with diabetes that are hospitalized, does the hospital conduct an A1C test on admission for patients with diabetes unless a recent test has been documented? And of course, as we've discussed, meals and inpatient insulin regimens are quite important, and if done incorrectly, can result in severe hyper or hypoglycemia, which is very dangerous. So do hospitals around meal times ensure that there's appropriate monitoring of blood glucose, document the amount of food consumed so that both providers and nurses can be more insightful in terms of giving the right amount of insulin? Do they do proper timing of insulin administration? And is there information available for patients regarding the carbohydrate content of their meals? Next slide. Now, for patients specifically going for surgeries, specifically scheduled inpatient surgeries, do hospitals ensure that patients with diabetes have appropriate preparation for scheduled surgeries, really to set them up for success, including preoperative assessment, medication management, either adjustments or suggestions or advice, such as holding or continuing certain types of medications and their timing, and appropriate monitoring of glycemia during the procedure, as well as treatment as necessary. Next slide. And then for our high-risk patients with diabetes, as we mentioned, those that are potentially high risk for either having complications or for readmission, are there specialized care teams and patient education that can be deployed to help care for these patients and educate them to ensure best outcomes and reduce readmission risk? Also, really, the time of discharge planning, I really feel like the time of discharge and discharge planning might be truly the most important thing that any one of us do in the inpatient setting. Do the hospitals implement a comprehensive discharge process for high-risk patients with diabetes that includes post-discharge care coordination, medication management, patient education, as well as several other items that you'll see in the application? Thank you, Leah.
Okay, well, thank you for that overview. That's again, the application will be available on November 8th, the actual application. You certainly can start preparing now. And we do have office hours and help desk support coming in November and December. The application will be due on January 15th again. You must also participate in the Leapfrog Hospital Survey 2023 in order to be eligible to complete this application. And then there will be some corrections or other feedback you may get on your application, which will need to be submitted by January 31st. And then in the spring, we will be having lots of parties and awarding leaders and recognizing them. That's the best part. And we really look forward to being able to do that, because this is so important. And the leaders of the first year are especially important, because you're the pioneers. You're going to show the rest of the country how it can be done. And we're excited to learn from you and to recognize you. So I think we had one question in the Q&A. I just saw a question. For the surgical, actually, John Luke, can you read the question? I'm not sure which one.
Yeah, sure. So the question is from Lindsay. She asks for the surgical patient section. So now, is that just for elective surgeries or for patients who are already hospitalized and undergoing procedures during the hospitalization? And actually, Missy typed out an answer before we got to it, but so Missy clarified that it's for scheduled inpatient surgeries. So that's both patients submitted specifically for a scheduled inpatient surgery and patients who are undergoing a scheduled surgery while they're in the hospital. But now it doesn't include patients who are having an emergency procedure.
Does anyone want to comment on that as well? And see that Missy did as well. Yeah,
Well, I think we kept it to scheduled surgeries because for emergent surgeries, they're handled a little bit differently, and it's unfair to request preoperative assessment, a formal outpatient preoperative assessment, or potentially even preoperative hemoglobin A1C testing when it's an emergency situation. So we did limit it to planned surgeries.
I think I have a question for Tara. As you look at the overall application and the question that's almost done, and the application and the standards, do you think that this will make a real difference? Just looking at the whole thing, do you think this would have made a real difference in your own experience?
I do. It's definitely something that I would and will look for in the future when looking for care. I do think, anecdotally, when I was looking for a hospital to deliver at when I was before I had my son, I shopped around providers to find someone who would let me use my insulin pump throughout my pregnancy and then through labor. That was a real thing, and I know that might be slightly separate from this, but that was I scheduled a lot of appointments with a lot of doctors to try to get that information. So if this is something that is readily available, a signal that to patients like myself that you all are thinking about patients in this way and have the expertise to care for the many complexities of diabetes, it's definitely something that would be useful to me. Yes.
Well, that's certainly something we're going to. I mean, it's got to be for any patient, no matter why they're in the hospital. But if they are diagnosed with diabetes, there's a certain standard of care we'd like to see them get. Period. So very exciting. Dr. Umpierrez, what do you think? Does this address some of the issues that you've seen in your research? You're on mute.
Definitely. This is, our research has been very clinical and trying to answer a specific question: what is the best treatment? How do you should do it? How do you adjust insulin? We have been involved in multiple studies now with technology. How does CGM helps with how blood glucose monitor, how often it should be. We have been involved in discharge. So I think that the guidelines or suggestion on how to improve diabetes care that is being proposed by Dr. Demirovich is there are right on target. This is what we think every day. And I think that Leapfrog and the ADA has put together very simple, you can go to a lot of recommendations, but these are the basic recommendations that I think is going to make a difference in the hospital diabetes care.
Well, I think that's a very important statement since you've looked at the problem for so long and certainly are a critical expert in this topic. I think it is important to know that these are some steps that hospitals can take, and that you're comfortable with them. That is, I think, a positive sign for all of us. Okay, so what about you, Dr. Debbie Dowich? What do you think?
I think that, of course, the ADA standards of medical care are just an amazing set of codified guidelines for providers and hospitals to follow. And what makes this program so exciting is that it takes it to the next level and sets benchmarks or expectations of how frequently we expect hospitals to be following those guidelines. Because guidelines is a general kind of catch-all situation. But this really says, okay, so we really expect folks to actually be doing this frequently, which I think, again, it really helps quantify the frequency that you're following the guidelines. And it really helps recognize the hospitals, they're doing an excellent job. And I think it also helps inspire other hospitals to get an understanding of how frequently they are doing it or are not doing it, and then inspires them to get better. Without understanding where you are, you don't know where you're going. And I think that by having this program, it really is like the tide that rises all ships. So I think it's a really, really exciting program.
Yeah, and there are multiple hospitals in the United States and all over the world that don't have diabetes specialists. They don't have diabetes educators. So having these kind of guidelines to set up at least the basics to how to perform well are necessary. There are hospitals who has services and companies and hospitalists who are specialists in diabetes care, but there are many who don't have that support. So I think that this is why these recommendations for recognized leader in care for people with diabetes is so important.
That's interesting, because almost every employer that I've ever worked with or talked with has invested their significant resources in caring for their own employees with diabetes. They are very invested in this issue, and they really care about it. I don't think most have thought about, well, what happens when they get admitted for whatever reason. So I think they will be I know they're extraordinarily interested in this program for that very reason, because they don't know what to look for. And I think it's very exciting to them that the hospitals are stepping forward to be leaders in this area, and to give them this, to be recognized for this, and to show that they do care about this particular issue. So I think for employers as well, this is a very, very positive development. Dr. Gabbay, when we first talked about this issue, you were the one who really educated me on just how important this was, because you yourself have heard from lots of your own members about this problem. Is that true, or you feel good about this?
Very, very, very true. Not only from sort of our professional members that are in hospitals where they know that there's opportunities to improve, but also for the people living with diabetes that we represent. And I've seen it firsthand. I'm also an endocrinologist, and being on the inpatient service, one sees a lot of these gaps. And I think what's exciting about this program is that, over the years, we've accumulated an incredible amount of knowledge about how to do it right. What can reduce those numbers, the differences on the graphs that you saw between people with diabetes and without diabetes, or people with hyperglycemia and good glucose control. So we know what works, and this is really about making that happen, and recognizing those hospitals that have already taken those steps. But also to help the hospitals have a roadmap of how they can provide exemplary care. And honestly, this is of interest not only for better patient outcomes, which we all want, but when one thinks about the total cost of care, all of these complications and extended length of stay and other issues that occur as a result of many times not these guidelines being followed, really have a huge impact as well. So this is a great roadmap. And I guess the last thing I'd say is, and I suspect this will resonate for many in the audience, We sort of know that it's really hard to improve something unless you start measuring it, because we all tend to overestimate the quality care we give. Certainly healthcare professionals, we do as a group, and there are many studies to show that. So starting by just measuring where you are is a huge first step. And so really excited that those here in the audience are committed to do that, to be able to follow this roadmap.
And we're excited also that ADA and I'm excited about Leapfrog too, of course, are really wanting to spotlight that performance, because I think this does take some effort, and I think and it takes some investment in having a diabetes educator, for instance. It's really important. We want to see every hospital do it. It's obviously lives are at stake in doing it, but it's still unfortunately not the not the standard right now. So hospitals that do take that step and are pioneers and want to do it deserve that recognition, and we're ready to give it to them. So that's full speed ahead. All right. Do we have any questions from the audience before we conclude our session today?
So maybe I'll just repeat one from the chat here that I think is really important. So Drew asks if are we going to require any evidence or compliance data for these indicators? So the answer is yes. So for those indicators that Andrew described as those care process ones, we'll ask hospitals to collect 3 different samples of patients, one for each of those categories. So surgical patients, hospitalized patients, and then high-risk patients, to see whether those care processes that we described applied or were part of their care for each of those patients. So we'll have details on November 1st. That's what we mean by you can start to prepare their application. We'll have a PDF copy of the application that'll list exactly what questions we'll be asking and the specifications for data collection there. And of course, if you have any questions after you've had a chance to take a look at that document, you can reach out to our help desk and we'll be in touch.
Thank you, John Lutelli, whose leadership at Leapfrog has been excellent. So thank you for your incredible work on this as well. Okay, well, without more questions, let's we'll conclude our session for today. I want to thank all of our panelists. This was, and not only for participating today, but really for your extraordinary work on this project. We definitely relied heavily on all of you and your expertise, but also your passion for this. And I think we are all looking forward to now broadening our expert family, let's put it that way, to include hospitals who are doing this work. And we're looking forward to learning from them as well. But thank you all for participating, and thanks everyone for joining us.